people from a lot of parts of the world that we have the pleasure to share with them our passion, that is the shockwaves. I'm Dr. Gilo from Chile, from the southern part of the world, working a lot of years in this, and I'm a member and past president of OLAT, the Ibero-American Federation of Tissue Engineering and Shockwaves. And today we are continuing our webinars to interchange knowledge with people of all the world. Today we have the second webinar that we have done monthly. We think that we are going to continue doing 5 of these webinars of each part of our body where we can use shockwaves. And today we are going to continue with the upper limb extremity and the treatments that we can do with this. We have the honor today to have between our participants the best of, in my point of view, the best of this people doing this in a lot of parts of the world. We have our president from Argentina, Dr. Moya, is an expert in shoulder. We have the pleasure to have our friend Sergei Thiele from Germany, that is the cradle of the study of the shockwaves. He and his father, that have the pleasure that I knew his father, that he was a great participant in all the knowledge of this technology. Then we have another great participant, our friend Carsten Noglos from Germany too. He is an expert in hand and also in aesthetics, and also from South Korea, my new friend Park Kausung, that he is going to speak us about trigger points. We have also a very important person from us, that is Dr. Ram Chivandram from India. He is going to present, he's beginning his experience in shockwaves, but he is going to present how he's doing this in India. So I only have to say hello to everybody. Thank you to be here. And I will ask our president, Dr. Moya, to begin his presentation and our improvement of knowledge that we need for everybody of you. Please, Dr. Moya, I give you the word. Thank you.
Thank you very much, Leonardo. As you said, we have friends from all over the world, because I must confess that in some way, this is also a meeting of friends who have not seen each other for a long time. We have, as you said, Dr. Kwang Sung from Seoul, Republic of Korea. We have Dr. Ram Chidambaram from Chennai, the east coast of India. Our friend, Dr. Ashok from Mumbai. We have Dr. Sergei Thiele from Berlin. We have Dr. Carsten Nobloch from Hanover, Dr. Sergio Rowinski from Brazil, who is going to be kind of the guy from outside that is going to ask us. He's an orthopedic surgeon, a great shoulder surgeon. He will ask us and discuss with us the results we are showing. You, Dr. Leonardo Gilo from Chile, and myself from Buenos Aires. I am very happy to be part of this webinar. And I want to thank OrthoTV for the support that we always receive from this organization. In my case, I will speak about shoulder pathology. And we all know that shoulder pain is a reason for patients coming to our offices all over the world. It's one of the most frequent causes of pain in the musculoskeletal system. But even though most of the cases that we face are functional problems, we must know that there are different injuries as rotator cuff tears, and sometimes these pathologies are tricky. This is a case I received at my office, a 67 years old patient with diagnosis of rotator cuff tear that we can see on the MRI in the left side. This person had two indications of arthroscopic repair by two different surgeons and one indication for open repair. And he came to my office to have a second opinion, let's say a fourth opinion, and to decide if open or arthroscopic surgery. And I saw the rotator cuff tear, but I also saw the shape of the humeral head. And I asked the patient x-rays and a scintigraphy. And in fact, what the patient had was a prostate cancer metastasis and would have been a disaster to operate on this shoulder. So the same applies to shock waves. To have a shockwave device or a device of radial pressure waves does not make us or transform us in specialists of a topic. So we must also be very aware of these situations and do not treat symptoms. We must treat diagnosis. Said that, we must emphasize that according to the use of shock waves and radial pressure waves in shoulder tendinopathies, we have two main indications: calcified tendinopathies and non-calcified tendinopathies. Calcified tendinopathies have a thing that's very good for us, that the tissue have regeneration capacity. And this is demonstrated because sometimes it is spontaneous without our intervention. But non-calcified tendinopathies that are related with the degenerative process, have a limited regeneration capacity, and we must know that, and we must decide in which cases it's worth to go ahead with a treatment that is not invasive and regenerative, and when it is not a good idea to do so, and we need to choose another option. Speaking about calcification of the rotator cuff, this is the typical image. Most of the locations are on the supraspinatus, but we have seen calcifications in the infraspinatus, in the teres minor, and more frequently than in the teres minor, in the subscapularis. It has been described, as I said, that this is a self-limited process in some patients. We began from a normal tendon. At one moment, we don't know why, there is a metaplasia of the tenocytes that become chondrocytes, and we have the appearance of vesicles with hydroxyapatite crystals in the cytoplasm of these cells. And so we can see in the calcific stage on the x-rays the presence of the calcification. This phase can last a long time, and in some specific cases, there is a resorption, a spontaneous resorption of the calcification, and we go back to the normal tendon. So by definition, it would be a self-limited pathology, but the point is that this does not happen in most of the patients. Many patients stay in the calcific stage, so in those cases is where we participate trying to move on the situation. What about the symptoms? Generally, in the precalcification phase, people are asymptomatic and there are not X-rays changes. In the calcification or formative stage, we have variable symptoms, but generally they are comparing to what we used to call an impingement syndrome. They are chronic symptoms, not sharp pain. But for those patients that go to the reabsorptive phase, sometimes there is a very acute and sharp pain that is very difficult to manage, and thus is called the colic of the shoulder. It's comparing with the pain of a heart attack. It's very, very intense. And finally, we must stress that there is a post-calcification phase in which, even though the calcification has disappeared, for some time the pain remains. And it is good for us to know this because for the beginners, you will be surprised that in some patients, you treat the patient with shock waves, the calcification disappears, but the pain remains. And that's not a problem. Generally, it takes 1 to 2 months for the pain to disappear. We can classify the calcification according to their size, and we speak about with the Bosworth classification: tiny when they are barely perceptible, medium when they are less than 1.5 centimeters, and large from 1.5 centimeters up. But a classification that is very useful for us to make decisions in the treatment and to have an idea of the prognosis is the Gardner classification. In these classifications, type 1, as you can see, are calcifications that are very dense, with sharp borders, homogeneous content, and this is a calcification in an initial phase. Then we have the type 2, that there are two possible alternatives. One is to see a calcification that has an homogeneous content, but the borders are not clear, or just the opposite, clear borders with an heterogeneous content. These calcifications are more advanced in time than the type 1, but they are still far from disappearing spontaneously. And then you have the type 3 that are really very transparent, translucent calcifications. And these type of calcifications are very close to disappear spontaneously. So generally, we do not proceed with any kind of treatment besides treating the symptoms. Sometimes this stage can last a little more than we expect. And in those cases, perhaps the use of shock waves to make it more fast, to make faster the disappearance could be an option, but it's not common. We also can use ultrasound that is very sensible for the diagnosis of calcifications, but the problem is that it has not a prognostic value at the X-rays. And MRIs are good to rule out associated pathology, but they are not the best way to diagnose calcifications. Sometimes they do not look clear in this pathology, the calcifications in this kind of studies. The classical therapeutic alternatives were rehab, subacromial corticosteroids, percutaneous needling aspiration, and lavage, what the French used to call barbotage. Now, in the last years, ultrasound-guided needling has become very popular, and of course, open or arthroscopic surgery. What about rehab? Well, it was stated that the results of rehab were very good, but some authors have pointed out that even though we can have initially good results, there is a deterioration of the numbers with time. After 1 year, we went from 85% of good results to 60% of good results, and in many cases, it becomes as a chronic pain that is coming and going, and the people live with their pain that is not acute, but is always there. There are some negative prognostic factors that can show us that the patient has not a big chance of good results with rehab. And one of them is the presence of bilateral calcifications. Generally, those patients have 2 times more options of have a bad result with rehab. Another thing to consider, and as you can see, we can evaluate and see these prognostic factors just with X-rays, is a high volume of the calcific deposits, the medial extension of the calcification going beyond the acromioclavicular joint is another uh, bad or negative prognostic factor. And finally, the location in the anterior portion of the acromion, what we can see here as the area 0. In those cases, we can expect not as good results as we can expect with rehab in other type of patients. When we did not have shockwaves, that was in my case 20 years ago, I decided surgery when there was a failure of conservative treatment, when there was a symptomatic progression, or when I was dealing with a constant and unmanageable pain in the patient. In those cases, we decided generally to go ahead for open or arthroscopic surgery. But after shockwaves appears, we change our indications. And we know now that the use of focus shockwaves in patients with calcifications is an approved standard indication by the International Society of Medical Shockwave Treatment, because there is enough amount of evidence in the literature, in the scientific literature, to support this. We performed a study, a review study with a group of colleagues, including you, Leonardo, that this paper was published at the International Journal of Surgery in 2015. And we evaluate the information in the literature, and we concluded that this is a non-invasive, safe, effective, and efficient method, as I will show you later. In 2018, we published this paper at the Journal of Bone and Joint Surgery, making an analysis of the results according to the literature. We also used the grade of recommendation proposed by this publication, and we found that for the treatment of calcific tendinopathy of the shoulder with focused shock waves, there is a grade A recommendation. That means that there is high level of scientific evidence, and we should move from our classical method of treatment to this new one. We have seen that the good results are related with high energy. So there is no we cannot support the use of radial pressure waves so far, at least for massive use, because the information that we got in the scientific publications is insufficient. So we have more evidence for high level of energy and for focus shock waves. These are 3 papers. The first one is a comparison between shock waves and open surgery. The one in the center is a comparison between arthroscopy and the use of shock waves. And they demonstrated that shock waves are equivalent to surgery. The results are comparable. But what we see in the third paper on the right side is one paper that we presented at the International Congress of Shoulder and Elbow in Jeju, Korea, in 2016 with Silvia Ramon and the group of Quiron, where we demonstrated that the use of shockwave is not only effective, it's also efficient, because we save from 6 to 7 times the amount of money comparing with arthroscopic surgery with similar results. We always include a rehab program because shockwaves does not give a solution for scapular dyskinesia, for stiffness of the shoulder or muscle atrophy. So we need always to include a rehab program. And these are some cases to show you before and after, as you can see here, with 3 sessions of shockwaves. The results are very, very surprising. And of course, we not always get this, but we get this in an amount of 60 to 70%, in which completely disappears the calcification. We have another group of patients in which the calcification disappears partially. And we have some patients in which calcifications do not disappear. I have had patients with the same calcification in both shoulders. I treated both shoulders with the same device, with the same dose, and I got the resorption in one side and no resorption in the other side. I have no response for the reason. There are side effects like syncope. We have had syncope in some patients. It's very sensible, the area for some patients. We have had erythema. I have seen patients like the one I'm showing you with a hematoma, and this patient was treated with a device that was a radial pressure device by someone who had no experience. And of course, acute pain, sometimes related to the acute resorption of the calcification. So we can tell you about the use of shockwaves in calcifications of the rotator cuff, that there is a lot of evidence supporting this. Not being an invasive method, it is our first choice when rehab has failed, and it is efficient to treat and to give the patient a good solution. What about non-calcific tendinopathies? Well, the situation in this is completely different. We can see in the literature many review papers showing that there is no evidence. We can see even systematic reviews with no meta-analysis with no clear results in the use of shock waves and radial pressure waves in non-calcific tendinopathies of the shoulder. In the paper I showed you before, the result for the use both of focus and radial waves in non-calcific tendinopathies of the shoulder was grade C. That means that there is controversial information in the literature. But one of the points that I would like to make is that calcification is a very clear diagnosis, and non-calcific tendinopathies, we all, after 50 years old, have a non-calcific tendinopathies of the shoulder, but we do not know if it is the reason for pain or not. There have been described more than 90 differential diagnoses for shoulder pain. So I feel, and we make an analysis of with Silvia Ramon and with Federico Alfano that we presented at the ISMC Congress in San Sebastian, in which we analyzed the papers in favor or against the use of waves in non-calcific tendinopathies of the shoulder, and the quality of those papers is bad because they have no clear inclusion or exclusion criteria. The diagnosis of the pathology is not done according to the parameters of shoulder surgeon point of view. There are many things that are not clear, so we cannot expect to have good results with meta-analysis or reviews of papers that specifically are not well done. So we cannot recommend the use of radial pressure waves and shock waves in a massive way for patients with non-calcific tendinopathies. Even if we look at the protocols of these papers, you can see in red the ones that are against the use that have bad results, in green the ones with good results. And you can see, for instance, if we analyze the interval for applying waves, there you go from 3 days to 14 days. If we analyze the number of sessions, they go from 2 to 6. The number of pulses from 700 to 3000. The dose from 0.01 millijoules from 0.78 millijoules, and the frequency from 2 hertz from 12 hertz. So it is impossible, even if we consider the protocols, to give a recommendation. So there is lack of compelling evidence to support the use of radial pressure waves and shock waves in non-calcific tendinopathies of the shoulder, so we cannot recommend against or in favor of it, the use so far. We hope we will get better information in the future. And to finish, I give you an advance of the next webinar. We will have it on July 17th, including very high-level doctors as today, speaking in this case about lower limb. Thank you very much.
Thank you very much, Dr. Moya, for your interesting conference. But today we need to learn more and more, and we have to discuss more and more. So for that reason, we have people that can tell us by the point of view that they don't do shockwaves, but they do other treatments. Which is your thinking about this pathology, the calcifying tendinopathy and the non-calcifying tendinopathy, how we can do other treatments that we can be as successful as Daniel showed us with shockwaves. And especially I want to ask Dr. Rowiński, which is your thoughts about this conference, and what would you do with the Garner 3? For example, Garner 3, that is the only indication that we do, calcified tendinopathy. What would you do, Dr. Rowiński?
Well, so this answer is not difficult to me. Just for the audience to know, I'm Dr. Sergio Rowiński from Brazil, from São Paulo, and I am a shoulder and elbow surgeon who does obviously a lot of shoulder and elbow medical work for 17 years. So having said that, so whenever I have such a case, the first thing is that I really have to understand if we are talking about a real calcific tendonitis or not, because we have to remember that as per the literature, 75% of the calcifications of the subacromial space, they are not calcific tendonitis. They are innocent bystanders that they are over there for a lot of time. So we have to first, as Dr. Daniel said, establish a proper diagnosis with a clinical history and with the epidemiological data, okay? But when I pick up a case like that, and when I understand from a clinical point of view and a radiological point of view that I'm talking about a calcific tendonitis, especially a radiographical point of view, the way I have been managing these cases for 15 years is with subacromial injections, and they get better, and they really get better a lot. And then I follow them for a lot of time, and I follow them from a clinical point of view and from a radiographical point of view, and I always expect that not only they do better in the clinical aspect, but that that all of the calcifications will disappear over time in serial X-ray analysis. And believe me, it happens hopefully in the vast majority of the times. So subacromial injections have been my choice for 15 years, and I had I would say that 6 or 7 times in my life I received patients in the acute phase. And as Dr. Daniel was mentioning, the pain is very strong. It's like the heart attack of the shoulder, and they always want to go to the emergency. So when they come to me, I do immediately a subacromial injection with 6 or 7 cc of xylocaine. I wash all of the inflamed bursa on the subacromial space, and they really do get better, and they get better very fast. And I follow them for a lot of time. So this is how I manage them, and I have been successful. But I've been hearing for a lot of time about shockwave therapy for that, and it's always on my mind if my injections possibly doesn't work. But I have a question that, to Dr. Daniel, and even to you, sir, which is quite, I would say, it's rich in my mind during all of this lovely lecture from Dr. Daniel, which is when you pick up these patients, these 40, 45 white-year-old ladies, because it's much more common in white women in from 40 to 50, okay? In the explosive phase, they are crying, literally crying of pain. So there is something that people do, which is the barbotage, which I don't do, which is very common in literature. I do the subacromial injections with 6 or 7 cc of xylocaine. I wash all the bursa and it works. But when you pick up these ladies in the explosive phase, in which they are with so much desperation and pain, do you think that exactly in this phase, which is very difficult for the patient, there is a role for shockwave therapy exactly in this phase of the disease? I would really like to know from Dr. Daniel and from you, sir. Not in the chronic phase, I know it works, but in this in the explosive phase, in which is the pain drives the lady crazy.
In my case,
excuse me, Daniel, please let me answer this first.
Good.
Okay.
Yeah. The first thing, Sergio, is we have to divide the risk of our treatments.
Sure.
When we use non-invasive regenerative medicine that are energies applied to the cell that can make the cell response, you don't have possibilities, for example, of an infection.
Sure.
That is one of the most terrible enemies in orthopedic surgery.
Sure.
So first, when we start a treatment, we have to think about the risk that the patient is having. Second, in our techniques nowadays, we have another techniques that are not shockwaves that can make us put the pain less. For example, we use photons and laser of high energy. In my case, I use laser when I have that cases that you are telling me. And after that, when the pain goes down, I use shockwaves because we have two problems. We have the inflammation of the bursa and we have the tendinopathy with the change of the cell. And when we use both techniques, you can avoid the risk of putting a needle inside. And if we fail in that, we can continue with the semi-invasive regenerative medicine, as you can do putting inside some lidocaine or some anesthetic. So the risk is in the following step. And if everything fails, you can do the third stage, that is the invasive technologies as arthroscopy or surgery.
Sure.
So
Sure.
the problem is to understand the risk. And that's why I don't think that starting with a semi-invasive treatment is a good idea. It's not a bad treatment. It's not a good idea. Excuse me, Daniel, that was my point of view.
No, perfect, perfect. I think that this is a very good question, and your response is complementary to what I was going to say. It's perfect. Generally, I consider that if a patient is coming with that kind of clinical findings, is because it's going through the spontaneous resorption of the calcification in many times. So it wouldn't make sense to me to do a treatment in which what I'm looking for is it is what is going on spontaneously. So what I try to do with this patient is to control pain I prefer to use corticoids in the gluteus because the risk is much lower, and it has been demonstrated by some papers that the level of analgesia that you get comparing the injection in the subacromial space with the gluteus is the same, and
Okay.
the level of risk is much less. So I control pain and I follow up the patient with x-rays. If I see that it's disappearing, perhaps in 2-3 weeks, the calcification will disappear, most of it spontaneously. And if I see that the pain is controlled and the calcification does not move on, perhaps I can push it with a couple of sessions of shockwaves.
Can I make a comment? Can I?
Sure. Sure,
Okay.
please.
Okay. Yeah. I am getting all of this information. I am learning with you and with Dr. Daniel for sure. But there is one thing that I want to comment, okay? Because when you have I am still insisting in the explosive phase, which is not, we don't see every day, but this woman, they come desperate to the office. I have seen it almost 10 times in my life. And as I teach my residents, they want to bang the head on the wall. They are desperate. They come always crying. So literature is quite, I would say, it's quite evident about the fact that we have a phenomena which is called exudatus. The exudatus that comes from the explosive phase, in which you have a gigantic inflammation of the bursal. This is what the subacromial bursa, this is what we call bursal leaders. And you see, the idea of washing all of that with xylocaine and dismantling that, it's quite interesting. And I would still say that an injection is invasive, but if you do it properly in the office with asepsia, I don't know how to say, Daniel, asepsia in English, but you understand me. You know, if you clean everything with stereo instruments, blah, 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 it's still very safe. And all of this washing of the subacromial bursa can only happen if you're doing a subacromial injection. So, so in other words, when you do corticoids in the gluteus, you only have the pharmacological effect, the systemical pharmacological effect of the corticoid. But when you do it here, you have this, not a systemical effect, a local effect with a mechanical effect of dismantling all of the bursal leaders. So it's different, okay? And what's happening is different, and it makes sense in my mind. So having said that, in spite of the fact that Dr. Daniel said that the results are the same in the gluteus and in the subacromial space, don't you think that there are very serious and real advantages of doing what I do on the acute phase? I'm not being provocative, okay? I don't want to tease anyone. I am just being thoughtful about all of these practical ideas. And again, these patients, they come desperate to the office. So I want to give them in the office, in the clinic, what would be the most powerful option in my hands. But I guess I made interesting comments, and I would like to hear you guys. And even if Dr. Ham has something to say, we would love to.
I will just answer you so we can move on, not to get late. Yeah. But okay. I think that it's a very interesting topic, and I could also respond you well. But you are adding one more trauma. Okay. Putting a needle in an area where is inflammation, but I think it's a very interesting topic. In fact, we are planning with the Greek friends this mini battle comparing the subacromial injections with shockwaves. And so I think it's a topic, Sergio, that is very practical in everyday practice, and we can discuss it. It could be a reason for a specific webinar. But I think that I agree with you, and I am sure that you have good results with that method. And sometimes there are different ways to get to the same result.
Sure.
It's very interesting, this topic. So it's very interesting to hear another people talking, not only us, Daniel. we have to ask. Ram is raising this hand. So Ram,
Yes.
what do you think about this? And also Karsten, and also Sergey, and
Yes.
also Park,
I'm
all of the participants.
okay. I'm a high volume shoulder elbow surgeon, practiced in UK for 12 years and now currently for the last 10 years in India. But I'm a big proponent of shockwave as well, a contrasting person. Basically, in the UK, we have done a lot of arthroscopic surgeries for calcific deposit. We, in fact, reviewed our 40 to 60 patients, and we found that the proportion of them, when you do arthroscopic excision, they have a residual defect because you are removing. So the concept of shockwave is that you heal the tissue and you allow some regeneration to happen. So you avoid this residual weakness or defect in the rotator cuff. So
Sure.
that was the only thing which was attractive to us. So myself and my colleague Daniel Bock started to use in UK. They have used both focus and radial shortwave, more of focus. Now, what I want to, my comment about that staging, it is not like frozen shoulder because we have calcific deposit, but at the same time you have liquefaction and amorphous deposit. Patient comes with acute pain. In my practice, I just control the pain for with whatever measures we do for 2-3 days time, and when it settles down, we can go ahead with our regular protocol of whatever your favorite non-invasive treatment of choice.
Mm-hmm.
So it is not going through a strict phase. You always have a calcific deposit, liquefaction deposit as sclerosed again, and the whole symptoms can recur again. So that's one thing. Second thing, I want to ask one question to Daniel. Even in my practice, even if you see there is still persisting calcification or no complete disappearance, the patients are still much better with shockwave therapy, symptomatically, range of movement, pain-wise. So only about 10% of patients do have persisting problem. They require surgical intervention when you start to adapt this in the general use. Is there any factor in your practice you found these are the particular group of patients, they did not do well with shockwave?
Well, I completely agree with you. Our results when we made a review some years ago was that when the calcification disappeared, practically 100% of the cases have a very clear recovery. When we got disappearance that was clear but was not complete, was more than 50% but was not complete, 76% of the patients were very happy with the result, even though the complete calcification had not disappeared. And when we got no changes, I could tell you that from 5 to 10% of the patients are happy. But for me, there is a correlation between the amount of disappearance of the calcification with the clinical result.
Okay.
I think that we have this discussion is very interesting. I have another opinions to do, but I think that we have to continue. So I would like to continue with the second conference that will be done by Sergey Thiele from Germany. He is going to teach us how to do shockwaves in the shoulder, but excuse me, in the elbow. People that want to do questions, please putting in the chat. We were going to do the questions at the end of all the conferences. So you can do it in the chat of the webinar, please. And we are going to read it after all the conference. Sergey, please.
Thank you, Leonardo. And thank you, Daniel, for the invitation, actually. It's very nice to have in this time these webinars in order to get somehow the meeting point. And so hopefully we will meet together in person soon. But so far, I'm very happy that online is doing things like that. So, well, what I will talk about is the treatment of the elbow. And first of all, I have to say that there's no conflict of interest. And what I want to tell you is how the treatment was developed and how I am doing it nowadays. So the tennis elbow is more accurately described and understood as a tendinopathy of the lateral elbow, and it is a process of a failed healing affecting the common extensor tendon. So it's characterized by chronic degeneration at the origin of the extensor carpi radialis brevis muscle on the lateral epicondyle of the humerus. It is usually caused by injury or overuse. These injuries are mainly small injuries and repetitive strain injuries. So one of the most common tendinopathies of the upper extremity, and an annual incidence of 1 to 3% of the total population. Let me see whether I don't get it now. So what we are doing is that we do a clinical examination and taking a look on the rest pain, doing extension, the so-called Thompson test. We make a palpation on the radial epicondyle. We have a finger test. We have the pain on supination, and we take a look for the range of motion and, of course, the decrease of grip strength and pain at rest and during the night. But as well, we can see differences in the ultrasound, especially in the power Doppler. We can see the different situation of the inflammation, and that's where we can somehow make an answer about how the treatment will work. But of course, we as well have the MRI in order to see these structures and, as of course, see different differential diagnosis on these more or less clinical examination of the shoulder elbow pain. So here is the MRI for edema showing the lateral epicondyle. So what are the treatment options so far? We have the normal conservative treatments that are in use, like rest and movement restriction, application of ice, hot and cold treatment. We have analgesic medication with non-steroidal antirheumatics, taking it orally or topically. And we have, of course, orthopedic devices. There was already, in former times, a review on the, or attempted meta-analysis, I should say, as the author said it as well, of the treatment options on the epicondylitis of the elbow. And it showed very sad treatment options. So there's physiotherapy and, of course, the eccentric training and stretching, ultrasound showing not so good results. And what we can see often are the corticosteroid injection, which in my view should never ever be performed. Then of course PRP will rise and is rising already, and the surgery is always an option after failed conservative treatment. But then of course there's ESWT, and therefore we will talk about the options, what is the possibility on ESWT. So in the beginning of the 1990s, extracorporeal shockwave therapy found its way to the orthopedic treatment procedures, and epicondylitis was one of the first and obviously most successful treatment indications for ESWT. There were a number of RCTs that were performed showing the efficacy of the treatment, and for instance, the FDA approval in the US was one of the first after the plantar fasciitis. So the ESWT showed to be safe, non-invasive, easy to apply. We heard about that already before. Being non-invasive and an easy to apply treatment option should be one that should be well tolerated by the patient. But of course, there are high quality studies that showed not as strong results in comparison to the placebo as expected. So the role of ESWT for epicondylitis had to be discussed again, and we are somewhere in between, not markedly different from placebo and highly effective and reasonable alternative to a surgery. So what we did some years ago in the International Journal of Surgery and special edition, we did a review taking a look on how the scientific situation is. And what we thought was there were a number of negative RCTs by Crowther, Speed, and Millikan, but as well that could be included, we had a number of positive RCTs. And these were like from Rompe, who performed it and developed his work on seeing a lot of positive results. Pietroni, Spaka, Radwan, Gündims, they were included, and there are still some more to come. So what Rompe could show that was in a quite big group, 78%, 78 patients in two groups with a shockwave and a placebo group, that the shockwave was showing a significant benefit in order to the sham group, and so therefore this was quite a reasonable idea on treating these patients like that. So what already is to be seen is that he was always treating without a local anesthesia, but we will see that later on. Pietroni was doing an even higher number of patients with 114 patients in two groups, divided in the placebo and shockwave group, and as well was able to show in a 12-week follow-up a significant bettering of the grip strength and less pain. For the radial shockwave or pressure wave, however you will call them, it could as well be shown very good results in the Spaka work with 62% patients showing a decrease of pain and functional impairment and an increase of the pain-free grip strength. So therefore, radial shockwaves showed to be safe and effective as well. In former times in 2020, in quite comparable work was published by Zhao and Chen, showing that according to the pooled results, the early recovery from pain was accelerated by the VAs and measured therefore in the grip strength. And the authors concluded that based on the existing clinical evidence, extracorporeal shockwave therapy can effectively relieve the pain and functional impairment caused by tennis elbow, which better overall safety than several other methods, especially the corticosteroid injection. So for the patients unresponsive to conventional treatment methods, clinicians should consider shockwave therapy as possible alternative. So what I already mentioned was the lack of using local anesthesia, and Labeck et al. Showed in a work that showed a negative influence using a local anesthesia to the treated area, and therefore we always try to avoid these. The local anesthesia seems to inhibit the C fiber activity and therefore substantially alter the biologic response to the shockwave. So therefore, don't ever use local anesthesia in the treated area that you're going to treat. So after these controversial ideas about using or not using shockwave, we do see good results. And I do think, and I'm very keen on hearing what Dr. Park is telling us later on as well about the myofascial situation. And Sylvia Ramon had done very interesting work on the myofascial pain syndrome and fibromyalgia, and showing there these areas. And what I do, therefore, is as well that I do treat the muscle in combination to the treatment with the shockwave therapy. So therefore, I as well do a chiropractic access on my patients. And then afterwards, I do the shockwave treatment, maybe even combined with the acupuncture needle. And if I go here, you can see it as I go to the interesting area, then I do see that the needle is vibrating much more than it did before. So therefore, I do think that these are showing some results, because before I was already treating the muscle, and it should make a movement as well. So after all, what do? I do some combinations. I do a epicondylitis treatment with a focus device, and then I do myofascial pain treatment on the according muscles. And after all, then I teach my patients with a self-exercise, doing eccentric load strengthening and strength training together. So after these, I do see very good results overall. So thank you for your attention, and yeah, I'm looking forward for your questions.
Thank you very much, Sergey. Very interesting, your conference. And before doing the question to our friend Sergio Rubinsky that could tell us how he do this, I will make a little comment. I'm hearing in all the conferences that we talk about epicondylitis, and my way of saying this, that is a tendinosis of extensor tendons. Why we continue talking about epicondylitis and not epicondylopathy? Because when we think about inflammation, we think about steroids, for example, inside the tendon. And before doing the question to Sergio, why, Sergey, you tell us that it's an epicondylitis and not epicondylopathy? You think that is not a tendinosis of the extensor tendons?
I do think that it is an tendinosis of the attachment, of course. I do, and I do treat it as one in order to get a detonemization of the muscle as well. But as well, I do see an inflammation at the point. So therefore, I was taking a look on the Doppler ultrasound in order to see these inflammatory vessels there, showing us that there is inflammatory situation. We do have an edema that cannot be discussed as well. So no, I do see the point that we do have to treat the situation why this attachment is seriously in trouble, but I don't want to make a change of the nomenclature as well. So therefore, no.
Okay. Some authors say that vessels that you see in the echography are anormal vessels, are not inflammatory. Yeah. So I think that discussion would be for a webinar also. So it's my idea is to continue. So I will ask Sergio, you think that is it an inflammation? You use corticosteroids. What do? You operate these cases? You think that is a self-limited disease? What is your thought, not about SBT?
Okay, so the thing is, first of all, I love to discuss this. I love. Second, I would like to have 2 hours only to discuss lateral epicondylitis. I would love to, because I have a lot of things to say. Unfortunately, we don't have time, but I am suggesting you, sir, to do a webinar only on that, because we see new cases every day. And I started to listen to this 17 years ago when I started my shoulder and elbow practice, and I'm listening to the same story, and because we have the questions, but we don't have the answers. So having said that, before telling what I do, let me give you some very fast thoughts. The first one is, there is a classical description that the disease is not inflammatory, that it would be only angiofibroblastical tissue. I don't believe that, because I use it to send, when I operated many years ago, all of this, the tissue to anatomopathological analysis. And it was always written by the anatomopathologist that there was inflammatory tissue and inflammatory reaction over there. And besides that, as Dr. Sergey has said, we see when we operate that, which is very uncommon, a lot of vascular dilatation. So there is vascular reaction over there, which show us from a macroscopical point of view that there is inflammation. So we have macroscopical evidence and microscopical histopathological evidence that there is inflammation. So in my opinion, yes, it's an inflammatory and degenerative disease. So having said that, when I have cases with mild symptoms, I always start non-invasive methods with physiotherapy, but my practice has been, and I am very successful because I don't use shockwave therapies, to do something which I learned with Felix Savoy, which is a very famous shoulder guy from the United States, which is to do an injection with corticoids with what we call the percutaneous scratching of the periosteum of the lateral epicondyle. So I enter with a little bit of xylocaine and corticoid, and I scratch the periosteum of the lateral epicondyle in order to induce bleeding. And that blood would hence induce tendon healing. So whenever I started doing that, which was from 2012 to now, my results have been changing a lot. So I am adding corticoids with blood. So if we know that the blood vascularity of the tendons is poor. So I am adding blood to the region coming from the periosteum. And once I started doing that, my results changed tremendously. So I have been doing this and on a single shot, because I don't want to put a lot of corticosteroids on the tendon. We know that. And just for you to know, sir, I don't want to be, well, I would like to talk 1 hour about that, but from 5 years to now, there is a new product in Brazil, which is made in Switzerland, which is called Sportvis, which is hyaluronic acid, especially to use in tendons. And the problem is that they cost here in Brazil 30 times more than a single shot of corticoids. But in some cases, I have been using hyaluronic acid from tendinopathies, and my results have been outstanding. So, and I know that there are many studies being done now in the United States comparing the normal corticoid shots with hyaluronic acid, okay? But the problem is that we are waiting for results. But besides all of this, what Dr. Daniel has highlighted in his lecture is very serious. We have to think about the costs, yeah, because none of these things, they are free. So I have one option with the corticosteroids with the scratching, and I have, which is absolutely cheap, and I have something which is the new hyaluronic acid, with wonderful results, but it's very expensive. So having said that, the cost benefit and the cost effectiveness, I am still a big fan of corticosteroid injections with percutaneous scratching. And I would say that I operate basically zero cases, and I get 1 to 2 new cases a week. Surgery is a super exception. And just to mention, when I do the surgery, which is very, very uncommon, I do exactly what Nirshal says. I open the ACRL. I see the macroscopic alterations on the ECRB, and I just close it with anchors or without anchors. But Nirshal says, pay attention, everybody. Nirshal says that you must do on the surgery a lot of holes in the lateral epicondyle for blood to come. So it's the same idea that I do in the percutaneous injection. So the common denominator is, if you try to bring blood to the region, that would be quite good for tendon healing. I have been successful managing these cases like that. But I am absolutely, I would say, open ears to know what you guys think about that, or if you do something quite different.
Thank you, Sergio. We have to, this discussion would have, each discussion we have had now, it could be for a webinar.
Sure.
I'm not agree, you excuse me, I not agree with your point of view. I think that corticosteroids is not the best way to treat this thing. I think that Sergey would have something to say also. But please, Sergey, answer this and we continue then with Carsten, because if not, we are going to be discussing this 3 days. Please, Sergey.
Yeah, I just want to make a little point as well. And yes, I do see some people who treat very effectively with the corticosteroids. If you take a look in the literature, then you see a short-term effect. I don't know how these are in your case. Maybe due to your practice, doing some needling as well and trying to make a better blood flow and blood supply, you are more effective. That's possible, but I do see two aspects. I do see the bad aspect about the hyaluronic acid due to the tendon and due to the fat pad, subcutaneous fat. And what I do see is these women, beautiful women that are not able to wear short skirts anymore because they do not want to show their elbow because the skin has a dull and they have a problem there. So that's one point about the corticosteroids. The other point, and that's maybe much more my point, I do make a better blood supply in the area that I do treat with the shockwave. That we do see, and therefore I do see that is the reason why we are treating with shockwave this beneficial. And so therefore, that's one of the reasons why I do treat the direct area with a focus device, and then I do next to it a detonization for the muscle with a radial device. I do treat the information from the center, and therefore I do treat these tensions that are happening there, fascial treatment and stuff like that. So therefore, yeah, of course I do see your point, but I'm happy that I'm over corticosteroids so far.
Okay, good.
Thank you very much. Please, Sergio, I won't continue with this discussion, because if not, the time will pass and it's late for some of us. Adding only one point, we have to think that non-invasive always will be better in the first point from the invasive. Now we are going to go to the third point, that is our friend Carsten Nordblock from Germany, that are going to talk about hand and his great experience of this. And after all the conference, we can continue discussing for a while with the people of the audience. So please, Karsten, teach us about hand.
Dear Leonardo,
and shockwaves.
Dear Leonardo, dear Daniel, thank you. It is a distinct pleasure for me to participate in this very multi-international, 3-continent or even more conference now. So I will start on a tiny bone of the wrist, the scaphoid. And the scaphoid tends to lead to non-unions because of a poor vascular supply, and the major vessel is a retrograde vessel fed from branches of the radial artery. So oftentimes, given bones related or non-union rates are related to poor vascular supply. And this is the case if it comes to scaphoid fractures. The more proximal your fracture line is, the more likely scaphoid non-union will appear. So the area or the location of the fracture is of paramount in this aspect. Sergio Russo from Italy and his colleagues Bruno Corrado and others published in the 2000 book Musculoskeletal Shockwave Therapy by Mr. Coombs, Wolfi Schaden and Su, the up-to-date, still the by far largest cohort study on scaphoid non-unions. They included 153 patients with scaphoid non-unions. They used focused electromagnetic high energetic device, 4,000 shots, 2,000 from the dorsal aspect, 2,000 from Palmar, and they applied 0.5 millijoule, just to remember. And they were quite successful using this high energetic approach. This was published 2000. In my book, ESWT in Hand Surgery, Sergio, again, 19 years later, wrote a chapter on scaphoid non-unions, how I do it now. And if you look in his parameters, he's still using focused electromagnetic device. However, with regards of energy flux density, he uses only 0.05 to 0.12 millijoule, so low energetic in a way. And if it comes, or if you compare it to his approach in the late 90s, it is by tenfold less energies he's using now, in contrast to 20 years before, for even better results. So maybe one has to rethink even the paradigm of very, very high energies, even on the bone. You know, and this is one of the very first reports I'm aware of, that you can be very successful even with lower energy levels. There is another study just published 2 years ago from my first doctorate, Robert Kramer and his working group, using piezoelectric focus device, and they did in vivo management or measurements in healthy volunteers on the scaphoid bone perfusion, and they measured with a device called laser Doppler flowmetry the scaphoid blood flow, and they could show that within 4 or 5 minutes after application of piezoelectric, as you see, 0.3 high energetic shots, the capillary blood flow of the scaphoid is increased. I now introduce or just highlight a novel machine which I use in addition to shockwave. It's called electro or extracorporeal magneto-transduction therapy. So it is using high oscillating, very powerful magnetic fields. And this is a case, first operation, scaphoid fracture, first operation 2012, second operation, again with a bone graft and a Herbert screw in 2019. So 2 operations with bone grafting, no success. So in the first wave of COVID in March 2020 in Germany, I treated him with 3 sessions of ESWT, high energetic, and EMTT, and then did a 3D scan of his wrist. So this is the novel machine in combination with the shockwave. This is my 3D CT scan. And these are the images 5 weeks after the 3 sessions. And you see now, after nearly 9 years of scaphoid non-unions and 2 failed surgeries, within 5 weeks, a bony consolidation of a scaphoid fracture, just to give you an outlook. And this has just been published in Medicine. Another case on metacarpal fracture. You see here the development, antegrad wiring, not successful, then bone graft, and in my view, in my personal view, very short plate here. As you see here, the tiny plate with only 2 cortices taken, unsuccessful in the end. Again, 3 sessions focus shockwave and EMTT. You see here focus shockwave, the parameters high energetic, 0.35 millijoule, 4,000 shots, and 6,000 shots with the EMTT device in 1 session. And again, same imaging studies before and after within, as you see, March 20, April 30, 6 weeks in between. And you see here nicely the bone graft and the non-consolidated fracture, and then the consolidation within 6 weeks. Just to give you an idea, and has just been published in the German Hand Surgical Journal. So if it comes to thumb osteoarthritis of the CMC1 joint, there is the Eaton-Littler classification, and we will hear from Park later. Diagnosis, and Daniel already told us, diagnosis and localization is everything. And if it comes to bone or thumb osteoarthritis, I believe it's crucial to have a very, not only locate the pain, but also the degree of osteoarthritis. And I'm using the aforementioned 3D CT scan, and you can do this reformation work, as you can see here, but you can have plain scans as well. And this is, for example, just for description purposes, a Eaton-Littler osteoarthritis degree 1. This is, for example, degree 2 with some subchondral sclerosis and some loose bodies smaller than 2 millimeters. I do it usually with both hands simultaneously, so you have a nice view on the right and left hand side. Here, a 4th degree Eaton-Littler with subluxation, bone-to-bone contact, cysts, and so on, and adjacent STT osteoarthritis. So, and this is how I describe a patient before I offer any therapy. And if it comes to osteoarthritis of the thumb, I start usually with the orthesis for 6 weeks, and I offer shockwave therapy, focus shockwave in this case. I will show you the data. Then I offer, if I fail, injection therapy by intra-articular ultrasound guided hyaluronic acid, and finally surgery. That's my approach. And the best study I'm aware of on the osteoarthritis of the thumb is published in 2018 by an Italian group, comparing 3 sessions of focused shockwave and intra-articular hyaluronic acid injections done by ultrasound control. So they did 3 sessions of focused electromagnetic shockwave, 0.09 millijoule, 2,400 impulses, 3 sessions, or 3 sessions of hyaluronic acid ultrasound guided. They included rather old patients, 68 years, and long pain durations, 8 years, as you see here, and out of 10, a pain level of 7 to 8. So quite impaired patients. And this is the change in the visual analog scale with regards to pain, in black for the focused shockwave group, in white for the hyaluronic acid group. And you see a nice response in both groups immediately, 4 weeks after, 3 months after, with a tendency that at 3 months, the hyaluronic acid is a bit better, but at 6 months, the shockwave still improve, and the hyaluronic acid injection group declined. So maybe in that case, the 3 sessions of hyaluronic acid then work very good for 3 months, and then the medical effects they exert become less relevant, as you can see here in this chart. So another tendon disease is trigger finger. This is trigger finger of the thumb, of the flexor of the thumb, and usually let's say the swelling or the enlargement of a tendon, say an Achilles tendon, patella tendon, does not cause a constriction problem. However, on the finger it does, because if you have an enlarged tendon because of tendinopathy and inflammation, and I'm seeing inflammation 15 years every day with power Doppler ultrasound on every tendon. So it is, in my view, a fully inflammatory disease with some tendon changes structural wise. However, what is pain or causing the pain is inflammation. So the enlargement of the tendon is entrapped under the annular ligament. And you can now do it or visualize this by dynamic ultrasound with high resolution ultrasound. This is a 22-degree hockey stick probe I'm using on the finger for assessment of the dynamics of the flexor tendon. And you see here the tendon nodule with enlargement and its entrapment within the A1 annular ligament. My approach in trigger finger starts with shock waves. Second is injection therapy with either, because of the swelling issue, very tiny amount of triamcinolone or hyaluronic acid, or surgery at third stage. We have by now 5, actually another Japanese or Chinese study, 6 studies, mainly using radial pressure wave devices. The first by Nikos Maliolopoulos, published in 2014, then an RCT 216, cohort study here, piezo wave, and a combination of focused and radial shock wave in this group. Of note, the first study Nikos presented here on Shockwave Berlin in 2012. He was using radial pressure waves, 2000 shots, but only 0.4 bar and only very slow 5 hertz. So not 10, not 15, not 20 hertz, 5 hertz and 1.4 bars at that. So very low pressure and very slow. And he was the first, as far as I oversee, even for other tendon regions, to show that the longer the duration of pain before your starting of the ESWT, the more sessions of shockwave, in this case radial shock pressure wave therapy, it needs. So if patients has less than 3 months of pain, he was successful with 5 sessions. If a patient has more than 12 months of pain, he needed 8 sessions, just to give you an idea on how relationship is. And like the knives of the chef for different purposes in your given kitchen, I'm using different radial applicators, even in hand surgical setup. For example, in trigger fingers, I'm starting with Atlas and then move on ceramics and maybe using even different tools. So I'm changing even my applicators within a given treatment. So shortly on the carpal tunnel syndrome, a neuropathy or compression neuropathy, where the medium nerve is covered under the ligamentum carpi transversum in the carpal tunnel with adjacent 9 flexor tendons. And if on the one hand you have flexor tendinopathy with an enlargement of your tendons, the space within the carpal tunnel becomes less and there might be some compression issues. And the first study published on the use of, in that case, piezoelectric focused shockwave device was published by Pietro Romeo and Cristina D'Agostino in 2010. And they used very, very low energies, as you see, 0.03 millijoule in patients who already underwent unsuccessful carpal tunnel surgery. So in that cases, they could reduce pain levels quite significantly from 6 out of 10 to 2 out of 10 at 6 weeks and even further down the road. And there is a nice chapter by a Taiwanese colleague, Dr. Wu, in the ESWT book, highlighting at that point, published in 2019, the randomized control trials using on the upper panel focus shock wave, on the lower panel radial pressure waves. And it appears that on the one hand, clinical wise, patients improve, related to improvement in Boston carpal tunnel questionnaire, which is a validated PROM. Neurophysiological wise, the patients improve, and even by ultrasound. And you can measure some very special things like fasciculation and diameter changes of the nerve, of the median nerve, and they improve. So there is solid evidence even by now for for the use or for considering shockwave therapy in carpal tunnel disease. Some last words on Dupuytren disease. So in Dupuytren's, it's very crucial to differentiate the nodular stage, where you have only nodules and no contracture, where in Germany we offer radiation therapy or by now focused shockwave therapy. I will show you the evidence for this. And the other part is cord with more than 20 degrees of joint contracture, where if patient is impaired by that contracture, we consider as the gold standard open surgery, or we offer percutaneous needle fasciotomy, or we consider enzymatic fasciotomy with collagenase injection. We did a long time ago, actually, when I was still in the hospital, but published now, a study in painful nodular stage of Dupuytren's. We used focused electromagnetic device. It was published this January as a randomized controlled trial. And we did 3 sessions, 0.35 millijoule, 2,000 shots, in contrast to a placebo treatment. And we measured pain reduction, because we only included patients with painful nodules. And pain reduction was quite substantial. In white columns is the shockwave group, focus shockwave, in black the placebo group. And you see a significant improvement after 3 sessions at 3, 6, 12, and 18 months, and an impairment or more pain in the placebo group. The same holds true for some patient-related outcome measures like DASH score or a Michigan Hand Questionnaire or the URAM scale. So all improved, interestingly and notably, at best 6 months after. So it appears that even your 3 sessions of shockwave take some time to react in a fibrotic nodule when it comes to pain. And there was a further observation, however, this was not significant, but a tendency that over a follow-up of 18 months, we had less interventions for any Dupuytren related, say, injection therapy, percutaneous needle fasciotomy, or surgery in the intervention group, in contrast to the control group. So we concluded that focused electromagnetic high energetic shockwave can significantly reduce pain in painful nodules, and we found no adverse effects. And it appears, at least in the Dupuytren's, and the same holds true for Lederhose of the foot, that shockwave can work anti-fibrotic, because TGF-beta expression is somehow mediated or modulated, and in the end, by the modulation of TGF-beta on the receptor side, less fibrosis is coming out. So the anti-fibrotic action of focused shockwave is mediated or modulated by TGF-beta. Last case, 50 degree MP joint contracture in a female patient with chronic lymphatic leukemia during her chemotherapy. However, she neglected surgery. So I did the combination of Xiapex collagenase injection, as you can see here. She was on very low platelets, so you see a large amount of inflammation in hematoma. I'm combining radial pressure waves, focus shock waves as an anti-inflammatory treatment in addition with the EMTT. And you see here on the day I did the cord breaking, so you remember 50 degree beforehand, immediately after, and 4 days after, a significant and very rapid relief of the hematoma and the inflammation by the combination of focused radial shockwave magnetotherapy. So I conclude, I highlighted shortly that shockwave in the hand can improve bone healing, which we know from long bones, for example, on scaphoid fractures. We can improve, like in the lower limb, like on the upper limb, even tendinopathies, like trigger finger or de Quervain. We can improve carpal tunnel syndrome and maybe even other compression therapy neuropathies. And we can modulate and modify the cause of the disease in Dupuytren's. Thank you very much.
Thank you very much, Karsten. Very, very interesting, your conference. And in honor of time, I will ask all the audience to make questions, because we have to continue I excuse that we are not going to make a discussion in this moment because we need, in honor of time, to continue. So the only thing I want to say that we can combine physical energies to improve human tissues. And that has been demonstrated by all the conference that we have here today. And now we are going to hear Professor Park from Korea that are going to tell us how he do in myofascial points treatments with shockwaves or with combinations that he has a lot of experience. Park, please. I think it's a video that has to be put done by Professor Park. Please, thank you.
Orthopedic surgeon from South. Hello, everyone. This is Dr. Kwang-Sun Park, an orthopedic surgeon from South Korea. Today's topic is about treatment of trigger points around the shoulder.
Has stopped. Please continue with the video.
Sorry, Leonardo, what's the problem?
Okay.
Is any problem? Can you hear?
Yes, it's not now the video in the screen. Please put it again.
Okay, I will begin again. Do not worry.
Excuse to the audience. Please make some questions in the chat.
No, it's okay.
Yes. Hello, everyone. This is Dr. Kwang-Sun Park, an orthopedic surgeon from South Korea. Today's topic is about treatment of trigger points around the shoulder girdle with shock waves. I'm going to deliver my lecture with Steiko's facial manipulation concept. It might be somewhat strange and unfamiliar.
It doesn't hear, Daniel. It's a problem with the video. Daniel, is a problem with the video. Please repeat it. There's some problem that we can hear, and the screen is not, the video is not in the screen.
Let me check it because it was working with no problem.
Well,
sir, while playing the video, kindly do not minimize the video. You need to just open it and do not do any alt tab or something, you know.
Okay, we go again.
Yeah, otherwise it will not show there. Yeah.
Go ahead, Dr. Daniel. Try it out.
Good. Let's check.
Okay.
Hello, everyone. This is Dr. Kwang-Sun Park, an orthopedic surgeon from South Korea. Today's topic is about treatment of trigger points around the shoulder girdle with shock waves. I'm going to deliver my lecture with Steiko's facial manipulation concept. It might be somewhat strange and unfamiliar to you in a sense. However, I believe it will be beneficial for your clinic for sure. Well, let's get it started. Today's contents. After introduction about the principles currently practicing in my clinic, I'm going to demonstrate how to diagnose based on Cyrex and Steiko's methods. In this section, please do not forget localization is the most important concept. Lastly, after reviewing the current papers regarding ESWT using facial manipulation concept, let's go through further about new trigger points of shoulder, Steiko's center of coordination points. These 3 slides are the most important part of today's lecture. Here are the principles being practiced in my clinic also. Next, new trigger points, in other words, center of coordinations in scapular segment. Finally, center of coordination points in humerus segment. I really hope you get used to it. Well, Let me dig into further. To maximize the effect of shock wave within a limited time frame, since we cannot afford to treat every single trigger point, thus, it is never enough to emphasize the importance of localization and targeting. In terms of localization, I've been applying Cyrex's method for tendinosis and Steck's functional examination for myofascial problem all the time. In addition to the Dr. Daniel's previous excellent lecture, please note how to localize and target for tendinosis. There are 12 functional examinations. This slide demonstrates for the localization in deltoid muscle, localization in adductor muscles, localization in infraspinatus muscle, localization in subscapularis muscle. To understand Steckel's concept of facial manipulation, first, let's take a closer look at the fascia. We have found fascia, especially superficial fascia, has over 10 times more sensory receptors than muscle. Please keep in mind that it is another sensory organ. Let me tell you some interesting article. As a result of injecting hypotonic saline into each layer of subcutis, fascia, and muscle of patient with low back pain, the thoracolumbar facial layer caused the most severe pain. According to Carlos Tego's theory, hyaluronic acid in the deep fascia facilitates the free sliding of two fibrous fascial layers. When a problem arises here, myofascial pain occurs. Antonio Stecco said, when viscosity of hyaluronic acid increases at a point called center of coordination, the sliding system in the center of coordination decreases. Ultimately, symptoms arise at the center of perception. As seen in these ultrasound images of patients with low back pain, compared to the normal, it shows that the facial sliding system is clearly disrupted. Now, it's time to introduce radial pressure wave treatment technique using Steckel's facial manipulation concept. With the intention of eliminating facial densification using radial pressure wave device, in addition to compression, do back and forth, and even rotation, the concept of friction is the core of radial pressure wave technique. Here is an interesting study published in 2018, which is applied in the shock wave of Steckel's concept to treat the frozen shoulder. By applying radial pressure wave only, it has brought favorable outcome by setting treatment points for humerus, scapula, and arm according to the sequence concept. In the case of shoulder pain patients, as all muscles are always within the continuous fascial sheath, it is a principle to check the arm and forearm together with the scapula as a treatment point according to the movement. CC points in scapula segment. When shrugging a shoulder, in case of complaints of pain in sternoclavicular area or AC joint area, the lesion located medial to deltoid pectoral sulcus below the cricoid process is the center of coordination where densification are found frequently. Next, when the pain occurs in the position where both the scapula come together, CC point is located halfway between C7 and the scapular spine here. If there is a pain at the time of adduction, there is a center of coordination located anterior to the axillary line, while posterior to the pectoralis major border here. In case the pain occurs in the trapezius region during abduction, the point from the anterior border of the descending trapezius towards the posterior scalene is center of coordination. When sternoclavicular joint pain occurs during horizontal adduction, the middle one-third subclavius of clavicle becomes center of coordination. If pain is observed during scapular upward rotation, the scapular-thoracic rhythm is disrupted, and then the scapular superior angle, in other words, levator scapular insertion site, becomes center of coordination. Please remind these center of coordinations of scapular segments. If pain occurs during flexion when shaking hands, the short head of biceps attached to the coracoid process, located just below the deltoid anterior fiber, and the fascia of coracobrachialis becomes center of coordination. As a sequence treatment principle, if you check the midline to the lateral part of the biceps belly, treat it all together. The outcome of treatment is very effective. When pain occurs in extension, the location of the infraspinatus fossa at the intersection of ascending trapezius and posterior border of the deltoid attached to the scapular spine becomes center of coordination. It will be the best point for treating frozen shoulder patients with limited extension and internal rotation. The lateral head of the triceps should also be identified and treated with the longitudinal sequence. If anterior shoulder pain appears in this position, center of coordination is the location of coracobrachialis and the proximal one-third of the medial intermuscular septum extension. When treating more than 500 shots with radial pressure wave, along with distal one-third of medial intermuscular septum and resolving densification, you will get the best treatment outcomes. When lateral deltoid pain appears during abduction, if the pain spreads to the lateral epicondyle or trapezius area, center of coordination is the lateral bundle of the deltoid and the extension of the lateral intermuscular septum of the arm. If anterior pain appears during internal rotation, the clavicular part of the deltoid, that is, sulcus at the intersection of anterior deltoid and pectoralis major, becomes center of coordination. Performing the treatment can be improved by treating pronator teres muscle corresponding to the sequence. It is a good tip for the treatment point, so please make yours. Lastly, if posterior lateral pain appears during external rotation, such as a hair brushing posture, the posterior margin of the lateral deltoid will be center of coordination. This is the most important slide you should never forget. Let me show you demonstration. The target is the sulcus at the intersection of the anterior deltoid and pectoralis major muscle. I usually use 0.3 to 0.5 bar and 15 Hz as frequency. The technique is combination of compression, back and forth, and rotation. As using my own weight, it is easy to apply compression force in order to resolve densification. Next target is lateral bundle of deltoid muscle. I usually use 1000 to 1500 shots in a target point. Please check range of motion after treatment. In addition, as a sequence treatment, lateral intermuscular septum is good target as well. Thank you for paying attention to my lecture so far. If you have any comments, opinions, or questions to point out, please send me a message. Thank you so much.
Thank you very much for hearing this interesting video from Dr. Park. I will continue this this webinar with a case that Dr. Ram Chimbadabram from India is going to show us. And after this, we can continue with the discuss. And I ask everybody in the audience if they can put questions in the chat. Thank you very much. Please, Ram, tell us what is your case?
Okay, thank you. Am I audible?
Yeah, we see perfectly.
Yeah, okay. Thank you, Daniel, for your kind invitation to this August meeting and also offering me honorary fellowship of your federation. I'm very happy with that to learn more and about the shockwave therapy. I have been using shockwave therapy as a mode of treatment for selected patients, both in my UK and Indian practice. And I just wanted to share one case which has been recently treated. It's a 57-year-old homemaker lady presenting with pain in the left shoulder after lifting water pot 1 week ago. She had some pre-existing mild pain for 6 months, but no limitation prior to this. Now has severe difficulty in activities of daily living, continuous pain, night pain, sleep disturbed, unable to look after herself, do any work, had NSAID for 1 week, but no good result. So that was her range of movement. I just wanted to show this case as a case to demonstrate. So that is her right shoulder. That is her affected left shoulder. Abduction is hardly 30-40. Passive is also painful. That's a range of external rotation. And that's the, she couldn't reach even to hip or sacroiliac joint. So that is her x-rays. So was what we were discussing before, extensive calcium deposit, but some of them are clearly modulated, but some of them look fragmented. Remember the history dating back to 1 year ago, 6 months prior to as well. Should we just take some opinion about the classification? Do you use any classification? And what about any investigation? Daniel, in your practice?
Thank you, Ram. I see that this patient, I would like to check the passive range of motion just to know if the limitation of movement is related to pain or she has a frozen shoulder, you know, just not only the active. What I see on the x-ray are mainly two things. One is the calcification that for sure is not a type 1 Gerner calcification. Perhaps the acute pain that she is feeling is related to the reabsorption of this calcification. And I also see that there is a kind of drop in shoulder, perhaps related with the limited range of motion and atrophy of the muscles. But my first goal in this patient would be to control pain. I think that's the main point for me.
Yeah, but she didn't have any major pain or limitation of function prior to this. So I take your point. Sergio Rovinsky, what will be your thought?
Well, just a second. I'm not seeing myself, so but I'm not seeing myself, but can you see me? Can you listen to me?
Yes, we can see you.
Yes.
Okay, lovely. So one thing that I'm not seeing myself, but this is not a problem. So one thing that we have to understand is that everything starts with clinics, okay? So all of the time, I need to do a clinical rationale in my mind before seeing any exam. So the thing is, it's a 57-year-old lady with pain in the left shoulder for 6 months. And now I would say a well-defined trauma in time and space. It's not a high energy trauma, but it's trauma. And after the trauma, a very big difficulty to elevate the arm actively. So until proven contrary, from a clinical point of view, that would be a subacromial disease that evolved to a rotator cuff tear, and the physical exam resembles that. So we have an association with the clinical history and the physical exam. So having said that, I would like to know all of the examination regarding rotator cuff specific tests, if possible, of course. Everything starts with an X-ray, in which we have this interesting finding that maybe this can be, considering that clinics is sovereign and innocent bystander. And having said that, once I have to confirm or rule out a rotator cuff tear, an MRI is absolutely elemental for me to establish the proper diagnosis.
Take your point, Karsten. Would you do any further investigation here? Because clinically, it's difficult to assess the rotator cuff in a painful presenting shoulder with a limitation of movement to this extent. Would you be concerned about the rotator cuff integrity at this stage?
Definitely, yes. And this is why an MRI, it's a very important exam at this moment. Okay. So from a clinical point of view, I have a very typical subacromial scenario. We see this every day in the office, and then we have this interesting image. So I am seeing the CT, but I still think that
because what happened,
pathology must be confirmed or ruled out.
What happened? This patient was treated elsewhere for the first week. The patient had this sort of lifting water pot and then developing pain. So the treating surgeon at that place thought that is a GT fracture.
Okay.
He got the CT scan. I just wanted to show it. But my question to Professor Karsten Knobloch, would you do MRI to necessarily investigate this rotator cuff pathology here?
I usually opt to use the ultrasound first for a thorough look. However, especially if it's that's my approach. So I always do ultrasound, and then for a confirmation of my ultrasound and my clinical examination, I would opt for an MRI at best, because in Germany, for me it's quite easy to have a 3 Tesla MRI within 2-3 days in a given patient. If I'm not that sure on my ultrasound alone, and this might be the case in shoulder, then I would proceed to MRI. That's how I would do it.
Yeah, I agree with that point. But I think for the listening audience, we have to remember specks of microscopic small calcification may be sometimes missed by MRI, as well as hypoechoic or isoechoic lesion could be missed on the ultrasound. But in a large deposit, MRI ultrasound is useful. So this is the classification just to highlight. So this is the French orthoscopic classification, adding a fourth element. And that's the Bosworth classification type 3, more than 1.5 centimeter. So this is the clinical parameter. How do you proceed? What is your choice? First choice, Dr. Sergey.
Is Sergey there?
What will be your first move? Steroid injection, ESWT, needle aspiration, barbotage, arthroscopy? Okay, I think it's.
Can you hear, Sergey?
Yes, please.
I do have some difficulty in hearing. Sorry about that. So yeah, what would I do? I told I try. As far as I got this, that should be maybe a possibility for shockwave, but I'm not so sure about the MRI results that you thought or discuss because I did not hear as much. Needle aspiration, well, no, I don't like that too much. The arthroscopy would be too early. Yeah.
Okay.
So,
Ram, excuse me.
Yes.
Let me tell you something. Generally, with these cases, I would like to know if the limited range of motion is also passive.
Sure.
Or
I think I had a video, but I didn't put that here for lack of time. But that is my examination. It shows only a slight increase, about 10 to 20 degrees more flexion,
Good.
abduction than this range of movement.
Good.
I gathered that she had some small limitation of the movement prior to this injury, but it has become worse for the past 1 week.
Okay. So my point of view with a case like this is that the patient was dealing with a calcification of her rotator cuff before those 6 months where she was having a slight range of motion, a slight limitation of the range of motion, and some some pain, not big pain. And 1 week earlier, before you met her, she began with an acute pain, perhaps related with that very minor trauma, minor effort more than trauma. But it seems to me that this could be that she's going on an acute resorption phase. So in my office, what I do is my first goal is to control pain. I can ask the patient an MRI, but I am not concerned about the possibility of a rotator cuff. If she has a rotator cuff, I will evaluate that, but it's not an emergency to diagnose not of a rotator cuff. So what I would do is to medicate this patient. I would, as I said, give corticosteroids, intramuscular corticosteroids, and just ask for an MRI, check the evolution. Rockwood used to say that the 4 steps for treating shoulder pain conservatively is: first, control pain; second, recover range of motion; third, recover strength. And this patient, as I told you, she has a dropping shoulder because she has an atrophy of the muscles. And fourth is to maintain the exercises for a long time. So my first approach to this patient would be conservative treatment.
Yes,
can I make a point?
She had been, just to add information, she had been having analgesic, injection, everything for last 1 week, and is still persisting with pain with limitation of movement. So the treatment has been initiated by the treating surgeon for 1 week. Yes, Sergio?
The point, the point is that 1 week is a very short time for shoulder in this condition. You would need to expect and to communicate the patient that she will have pain for a longer time, and the time will help her. But you will not resolve this during just 1 week.
Okay.
Sure. Ham, can I make just one comment?
Yes, please.
Yeah, okay. So see, I learned it in medical college almost 25 years ago, and now I teach my residents this idea, which is a concept. There is no proper treatment without a proper diagnosis. So once the clinics is sovereign, I still have, in my point of view, to rule out, in spite of the radiographical image, the presence of not of a cuff pathology. It means a tear. So before, I know we have to manage pain, but I still have to establish, as all of the cases in my life, the diagnosis. So having said that, an MRI seems elemental to me to define the diagnosis. No proper management without a proper diagnosis. This is a message for the juniors, and I think that this makes sense in my mind.
But this, I agree that with that point. But can we make like as a must MRI for calcific tendinosis? Because the radiological diagnosis from X-ray tells you that it is a calcific tendonitis. That is part of the tendon is becoming into calcium. So there might be accept that there is a issue with the rotator cuff dysfunction. Could be that could be also a tear. I think, can we make a statement say that you must have MRI or not? We'll get opinion from Dr. Leonardo Gilov.
Okay.
Yeah, okay. Yes, please, I would like to say something. First, I agree with both. I agree with Tercio that yes, I agree with you because I think that the good diagnosis is a good treatment. So it's very important to know everything. But I agree also with Ram that if we have a calcium deposit, we can see if that calcium deposit is in what phase of the reabsorption. We must never do shock waves when a calcium deposit is in reabsorption in phase 3 of Gardner or even in phase 2, in grade 2. So in that case, that is with an acute pain, I should think that is in a reabsorption in that moment. So I have to do something for the pain and for the inflammation. After this, I would like to know if this woman have also a problem in his tendon rotator cuff, and if she have some rupture, I have to act in that way, looking this rupture, what is the size, and deciding what to do after that. But first of all, I will act in the reabsorption and never do shock waves in this case. So both, I agree with both. I think that everything is very important.
Leonardo, Ram, let me say one thing. I wouldn't do shock waves, and I wouldn't operate this patient even if she's having a rotator cuff tear, because if I operate the patient with that limited range of motion, I will have a bad result.
Yes.
So you need to have a strategy and say, okay, let's go step by step. First of all, let's put some, stop the fire here, stop the pain, stop the work on the range of motion, and then we will see. We can always ask an MRI, and I can always operate on this patient because it's not an emergency. To repair the rotator cuff. And there is something so clear and so obvious, the calcification, that I first want to address that, and then I have time to move on to the repair of the rotator cuff if it is necessary. The MRI rule out that.
I think going through the surgical route is absolutely not necessary, because if you excise all these calcium, you will be resulting in a defect or a tear which you need to repair. It's more disability, we agree. But as regard to the timing of shock wave in a patient presenting with pain in a calcific recurring episode, how long is your waiting time? Or in the X-ray, if you look at it, it is not completely resorptive stage at all. It is just fragmented, dense calcification with the starting of physical symptoms. So what will be your timing? Would you, how long you would wait?
Ram, I think this is not a type 2 Gardner. It's not a type 3. For me, it's a type 2.8 Gardner. This calcification will resolve, is diffuse, it is expanding, something that we see frequently. So I think that time will be the most important treatment for this patient. As we say, chronotherapy. So I just want to give the patient control of pain, perhaps very, very, soft exercises, and follow up her.
Okay.
And if you take X-ray in 1 month, you will be surprised that most of the calcification would have disappeared.
Okay. Well, just for the lack of time, I'll just show
Yes.
how I did for this patient, because I saw
Please.
there's quite a lot of dense fragments still there. I know there is this maybe starting of the resorptive phase, but as demonstrated in Dr. Daniel Moyo's lecture, even though you have a resorptive symptomatic stage starts, and if you give ESWT, it will control the pain as well as speed up the process. So that is something to think about. Managing pain after 1 week of intensive treatment. So I just did an ultrasound guided marking of the spot with ESWT. I usually use a focused shockwave, but because of the pandemic situation, it was done with the radial shockwave in my clinic. Ice pack application immediately after, simple analgesics only, mobilization as comfortable, and muscle strengthening after 3 weeks. So this is her at exactly 18 days after the first episode. So 3 weeks later,
please. Ram, stop
Yes.
there, please, because it's very interesting. Put that X-ray. You see there that you have in the bursa the calcium. That what you are telling is that reabsorption spontaneously. I don't think that SVT can did anything here. Your patient were doing spontaneously reabsorption, and you have there the proof that that was doing. So I don't. The problem is that this woman, with or without shockwaves, would reabsorb everything because she was in the reabsorption phase. And that X-ray is very interesting. Excuse me that I apologize that I ask you this, but yes, this is a spontaneous reabsorption.
Ram, I would like to say something.
Yes, please.
Yeah, so as a shoulder surgeon, there is something very interesting in this case, and I'm going to mention the fact, and I'm going to do some inferences. If you see the first X-ray, the humeroacromial space was enlarged, which is something that resembles rotator cuff suffering. And now with this current X-ray, the humeroacromial space is normal. So that gives me enough space from a physiopathological point of view to make the inference that that posterior superior rotator cuff was suffering somehow, okay? And now it's better. So from a physiopathological point of view, if the diagnosis is a calcific tendonitis, it was having a mechanical reflex on the posterior superior cuff, which is resolved now. This is interesting, and I think that this is very real. Dr. Daniel, do you agree with my inferences that I just have said?
Yes, I completely agree. And I think this is a very nice case because show us a kind of border situation in which no one would criticize RAM for doing the application, because it also had a kind of, as we see frequently, analgesic analgesic function and help the patient. But we must also state that this was a resorption phase. And we can see how the things can change dramatically if we wait for some time.
But you should, I think the key message is also, you should certainly avoid jumping to do some invasive procedure on seeing that presentation in the first phase, having somebody seeing with 6 months calcific tendonitis coming with symptoms, acute pain. Sometimes some surgeons jump to do intervention or unnecessary arthroscopic intervention.
Yes.
So then you could wait, let it settle down, and then you can plan your treatment. Or of course, shockwave as an adjuvant therapy as well to speed up the process of resolution. Second is to get good pain control, because this lady had complete disappearance of pain with the shockwave therapy and required only paracetamol as the analgesic. And it also allowed her to do with the rehab. In 3 weeks, she could regain full movement, including rotation.
You know, sorry,
Excuse me, Daniel.
images, yes, images can give you a lot of information, and images are showing me that perhaps I feel that Germany is going to play soccer soon. Isn't that right, Karsten? So
They already played 10 minutes. That's why I'm already, you know.
You,
and it's
you
the
see why
Paramount game.
Images
and I have guests, you know, that's why.
Showing. So we must consider images, and I think we should free our friends to watch the game, Leonardo. I think we are on time.
Dr. Park, want to say something?
Yeah,
Dr. Park.
I actually completely agree with Daniel's opinion before. And let me tell my opinion for Dr. Ram. You know, in this case, the first priority is to remove the pain, right? But even if after removing the pain, the range of motion remains still, my strategy is to make manipulation under brachial plexus block.
Okay.
What about your opinion?
I agree with you. Part is pain, movement, strength, and maintenance.
I completely agree with you. Yeah, right.
Yeah.
Dr. Park, can I make a statement?
Yeah, thank you.
Yeah,
please.
I agree with all that everybody have said. I am not a narrow-minded guy. On the contrary, I am an open-minded guy, but I stick to concepts all of the time. We are talking about management, but I still have to rely on diagnosis.
Right.
So I am right. So maybe if there is stiffness after the radiographical disappearance of the calcification, that would be a secondary frozen shoulder, okay? No doubt about it. And having said that, what I do and what Dr. Daniel does, because we discussed this in a previous webinar in September, is many times suprascapular nerve blocks, and they have been extremely successful to me. So we always have to think, I'm sorry I am being harsh, but I have reason to support my straightness. Besides all of the managements, we have always to focus in diagnosis, on the singular, on the plural, because I'm sorry, no proper diagnosis, no proper management. I am absolutely straight to this concept, and I dare to say that I am not incorrect in all of this straightness.
Right.
Excuse me, dear conferences, but I think that in honor of time, we have to make only a couple of questions to the other conferences. Thank you, Ram, for this case. That is very, very interesting. I think every case and every discussion here may be a future webinar. I hope that that could happen. The important thing is that everybody of us know that we can start with treatments without make any invasion in the body. We have to have an excellent diagnosis in all of the cases. If not, we can continue. And sure. I think that the order of these treatments and of this form of seeing the patients is very important for every people that is starting. So there are some questions that are in the chat that have been done in between us, but there are some very interesting questions. For example, for Karsten, you have tell us about tendinosynovitis and about Dupuytren, but there is some, in my experience also, very difficult tendinosynovitis, that is the Kerven, that have less good result when we use physical energies in the place. What is your experience with the Kerven? Is necessary to do this first, or we have to do surgery when we have these cases?
actually, in 2006, already 15 years ago, I made a paper for the ESCA journal where we did power Doppler ultrasound on the décovance and could show the very same neovessels, like in Achilles tendinopathy, right at the origin of the first extensor channel, I would say, you know? So it is kind of entrapment problem plus inflammation. And at that point of time, I did sclerosing injections and shock waves, and it disappeared. If it comes to shock waves focused and radial wise in terms of energy, this is it is very, very painful. And if you, for example, do radial pressure wave therapy with 2 bars with a steel applicator, this is not possible because it's too painful. So I am using the silicone tip from Storz. It's a silicone, let's say, device you mount on your radial device. And I adjust my pressures like Park in Seoul does at 0.3 or 0.5 bar, very, very low. This is not possible with every machine, I know, but very, very low, and with the silicon. And then I go 2,000 shots over the extensor tendon, plus do additional focus with very low energy again, 0.03, 0.05. So you have to somehow adjust your shock waves to this very painful location. That's the same holds true for trigger fingers. However, the décovance is even more painful, maybe the most painful spot you can imagine. So that's how I approach it. So same 10 shock waves. By now I do the magnetic field. I did prior in the past years laser therapy and injection therapy with polydocanol sclerosing or hyaluronic acid. That's how I approach. And the let's say the open release, it's, let's say, I do it once or twice in a year. So okay. Not that often. I see 1-2 patients a day with décovance. So not that often.
Perfect. At the other conferences, has the same experience that Carsten in this pathology? What do you think, Bram, about using this type of techniques in the décovance? You used to use it also?
Oh, I have no experience in using décovance.
Okay.
Only conservative injection surgical treatment. I have not tried shockwave there at all. But I'm very impressed by Carsten's result on scaphoid non-union.
Yeah.
With such a gap. Because I would have done revised that because I do hand surgery as well. I would have revised that, thinking that non-union needs compression, headless screw, etc. But my question is, how much gap you could accept if you are successful in healing with shockwave?
I would say, if it comes to an acute scaphoid fracture, first goal is reposition and fixation as usual. So do a Herbert screw. We are now talking on non-union, so I would not mix the acute assessment, although I'm a big fan of shockwave and can do everything. However, even if I would have an acute B2 type scaphoid fracture, I would receive a Herbert screw, Yes. But if then it fails before considering a bone graft, and I did, even when I was in hospital, I did vascularized bone grafts from a radial. So very sophisticated microsurgical things, And even then, I have a case where it does not heal. And I did 3 sessions of focal shockwave and then it healed, So in the non-union situation or in the prolonged healing situation, not waiting 6 months, but maybe 4 or let's say 8 weeks after your acute operation, and then no real healing. Or if you, for example, have a diabetic patient, osteoporosis, or some other risk factors where you say it's prone to develop problems, I would consider even doing it immediately after surgery. So there is one study not published yet, from Japan on metatarsal 5 Jones fractures. And they did focus shockwave after a screw at day 1, 3, and 5, and were 4 weeks faster back on field in Japanese soccer players. So I would consider adding shock waves immediately after surgery for even enhanced bone acceleration healing and like my magnetic field now. So that's how I would concern. But still, and I'm trained surgeon still, you know, so surgical indications remain surgical indications regardless of the beauty of the shockwave machine.
Okay.
I think
Park.
especially that aspect.
Excuse me, Park is a,
Yeah.
excuse me, Ram. Park is
Yeah. Let me something interesting for Ram, Dr. Ram. You know, actually, I have experience translating Dr. Carsten's great book, Hand Surgery in ESWT, into Korean. So the outcome is very, very effective, you know, because I really just follow his strategy, all right? So just believe him, okay? Yeah, especially for the requirement is easy. Yeah, the outcome is very, very effective. Believe it.
Proof is in the puddings. He's showing the result.
Dr. Leo, can I make a question to everybody?
Yes, but the last one, please, because we are on time.
Last one.
Okay, the last one question.
Last
yes.
one. I am asking everybody because I don't do shock waves. Dr. Daniel knows I am a shoulder and elbow surgeon who does a lot of shoulder and elbow trauma in my public hospital, and I operate a lot of cases and I treat many cases non-operatively. Having said that, when I'm managing a mid-shaft clavicle fracture conservatively, and I am having the perception in timeline from a chronological point of view and a radiographical point of view that it may evolve to pseudoarthrosis, because we know there is a gray zone in between formal bone healing and pseudoarthrosis. There is a gray zone radiographically and chronologically. In this gray zone, in mid-shaft clavicle fractures, do you think there is a role for shock wave to impede pseudoarthrosis? It's a good question.
It's a good question. I have experience. The only problem, Sergio, is that the lung vertex is very close to that area.
Okay.
That the subclavius artery is going very close to the clavicle. So I have used a piezoelectric device that has a very smaller focus than electrohydraulic device, and I have had good results. But I apply the shock waves tangentially, you know, just not direct. I try to go from the front and from anteriorly, just being very sure that I will not go through the lung structure.
I totally agree, Daniel.
Yes, I give you the
most.
Excuse me, Ram.
Only
thing that I have to say.
A good point to get there in order not to harm lung tissue and vessels. But if you have a point where you can get there and your device is able to have a focus small enough, then it is a good treatment option.
Okay.
For the people that are beginning, because there are some people that is beginning. Two things that are very important that you have said in this moment. We have to avoid the focus shock waves in every part where these shock waves can produce some risk. For example, in where you have air and you pass through the air with an energy that can explode inside the air, such a lung, such a digestive apparatus, you have to avoid to put shock waves there. That is absolutely a contraposition of this treatment. Never do that. So what Daniel is saying, we can treat a clavicle fracture, but if you are pointing to the lung, you will kill your patient. So never do that. And that is very important for the people that are beginning this. The contraindications, the most contraindications in the form we do, the shock waves, the focus shock waves, and even also the radial pressure waves, you have to be very careful in that. I think that for the people that is beginning is very important what you're telling. Ram, I think that you want to say something about this.
Only one question to Dr. Park Kwangson. Any experience in treating stiff elbow with shockwave? Any experience?
Sir,
Dr. Park.
Park, you're mute.
Yeah, Dr. Park. You are mute. Yes,
sorry.
yes.
Yeah. In case of frozen shoulder, my strategy is the first thing is injection. All right. So as I said before, after confirming the origin of a limited range of motion is pain or real primary frozen shoulder, we have to find the firstly. All right. So nextly, my strategy is manipulation after brachial plexus block.
Okay.
And then the remains of range of motion could be improved completely by shockwave, as I said in my lecture.
Okay.
Right.
Okay. Thank you. Well, I think that in honor of time for the audience also, I only have to say to everybody of you, thank you very much for this evening, morning, and afternoon that you have made a sacrifice today to be with us. But it's a pleasure to have been with everybody of you. Thank you. We have learned a lot, and I hope we could have in ONLAT people so interesting as you are in the future. Thank you, Dr. Moya, for lending us this auto web channel also, and for your presence, and say bye-bye to everybody of you, and invite to the people that are audience today to the next webinar that will be in the lower limb with shock waves, the lower limb treatment, and have a nice weekend, and thank you very much, and bye-bye to everybody. Thank you very much.
Thank
Bye
you.
bye.
Thank you, sir.
Thank you.
I have to go
Thank you.
sleeping. Bye-bye.
Good night.
Oh.
Good night.
Good night. Good night, Park. You're great. You are a hero. Thank you.
Okay.
Thank you to Ortho TV, and I think
you.
that if Dr. Ashok agrees, he's the boss here. I think this is a very nice team, and we should have a second round during the year because there are many questions, many topics, and I think it would be great to be all together again.
Absolutely.
Thank you very much. Bye bye.
Thank you, Ortho TV.
Thank you.
Bye bye.
Thanks, Ortho
Bye.
TV.
Bye.
Well done, Daniel.
Good luck.
You can stop the streaming, Jay. Jagan.